Did you have a good break?
Yes.
Yes. Anything exciting happening that you can tell that I don't know? Anybody get engaged? Married? Have a baby? No? Got a dog? Nothing. Okay.
They laugh at Heather, maybe.
Yes, Bama lost.
Yes, it did.
Sure, she's heard that.
Have you said that to Dr. Britton? Yeah, scared of you.
What did it test with you?
Okay, so today we are going to talk about pediatric prescribing. We're going to go through a series of calculations and practice in the very common ones. And Professor Lovett-Twan and I are going to do a tandem. So she's going to bring in the clinical pearls of practice. Anytime you can pick up pearls from people, always do. They are usually the things that experienced people have figured out, and they use them to bridge the gap or to make things easier when there's either nothing known or the more practicality. So in your handout today, there are sections in there for you to take notes on the clinical pearls, and there's also a place for you to do your calculations. You should have a set of blank prescriptions. I should have them finished by in the morning. They are going to look different than they have. They will be, some of them will be more, you will have to devise the order from the information given. So you'll be given a scenario, you'll be given what dosage forms are available. You will have to create the order and then make the prescription. Okay? It's much more practical, it's more real life. Please, this is the last set to do. I don't know when I'm going to be teaching in Capstone. Dr. Britton's decided to break up some of my time slots, so I'll ask him to put the prescriptions at the latest so that you'll have more time, because I'm going to have them graded and give them back to you that day. Please, please, please look at your laws regarding refills. Okay? Know those going out. You shouldn't ever be embarrassed going out not knowing what you are allowed to prescribe. Okay? It's where you all make the most errors in your prescriptions, even to this point. Usually many of you do it perfect until you get to the refills. Okay? So if you have questions about those today, bring them up. I'll go over it again. So those are the biggest things. And the other thing that you tend to make errors on is that I will give you pictures of dosage forms, and you totally ignore the picture. So I'll give you a picture of capsules because that's how they come, and you'll write down tablets. Take one tablet, okay? Look at the pictures I give you. I don't do it to make it pretty. I do it to give you practical information about what is available. The other thing I see that maybe never made clear is that when I show you a bottle, I'm usually just showing you a stock bottle. It doesn't mean that's the prescribing unit, okay? So if I give you a bottle that says 500, number 500 in the bottle, doesn't mean that's what you then dispense, okay? Most bottles are stock. They are what the pharmacist takes the prescription out of. Sometimes when they come in boxes or they do some type of special unit for dispensing, those are more unusual. Most things are going to come out of a stock. I'm telling you that because some of you will, whatever you see in the picture, you'll write as the dispensing unit, and it's not that, okay? So if I've given you a bottle that's even got 100 in it, it doesn't mean that's what you dispense. It depends on what you're writing, and how much you're writing for is what you write for. If it comes already dispensed as this unit, usually it will say it on the box or I'll indicate it in some way. Does that help? Okay. All right. On your objectives, this time, what I'm going to ask you out of this material is doses. The time has come. You have to know doses. So I sent an email to the second years, and I met with them shortly after they got on the rotations, and I've emailed them, and I've said, okay, based on pediatrics, what would you wish we had taught you then, from pharm perspective, that you didn't know going out? So the biggest thing I got back was dosing, dosing, dosing. And one person said, I was really embarrassed that when I got on my pediatric rotation, the first thing they were asking me is for an Augmentin prescription, calculate it, write a prescription. She said, I didn't know. So the things that I'm giving you, Professor LaVictoire and I've talked about, they're the most common things you're going to see. So you have to memorize them. You can always look up and verify, but you'll look a whole lot smarter, if that's your goal, when they ask you or you see someone and you can write it. The other thing I would advise is that when you start to go on a rotation, think about what are the big things I'm likely to see. I'm going on general medicine. I'm going to see hypertension, diabetes, heart-related stuff. Go in there and look at what the most common drugs are and start to memorize the dose so that when you get out there, if you have to look up everything, it'll take you forever. So the more you can do that, it'll just drive your brain back through material that we've already been through, and you'll remember it. You cannot look up dosing forever. It'll just slow you down. And eventually you'll learn them because you'll do them over and over and over again. But be prepared. Think ahead. What am I most likely to see? What do I need to know? Learn those. It'll go a long way. Okay, so on your objectives, number 3 gives you the medicines. It's what we're going to talk about today. There's a few others that we're also going to talk about, but I'm not going to hold you accountable for the dosing. And then there may be calculations based on those doses and a prescription or a dosage form. You will have to calculate those. So that's pretty much what I'm going to ask you out of this information. The prescription should help. They should drive some of this home. Some of the ones we don't calculate today will show up as prescriptions in your set tomorrow. Okay, questions? Okay. I am not posting the PowerPoint because it's got the calculation answers in it. So that's why it's not up on D2L. The information in the beginning on page 1 and 2, it goes directly or comes directly from what we talked about in the first module. One of the third lecture I gave you was on pediatric and geriatric dosing. So some of that I just pulled back in. It would be good if you would go back and look at that and refresh your brain either now or before you go on your peds rotation. So starting at the bottom of page 1, some things to recall. With kids, they're different. There isn't the information that you have in adults. You don't have the research scope and breadth and depth like you do with adults. It's a harder population to do research in from a number of standpoints. So here you're going to find dosing that's based on what adults do, and they have arranged it for kids. Some will come directly out of research, and some comes out of more practical experience. So there are age-based dosing regimens, and there are weight-based, and then there are body surface area-based. So on the age-based dosing, that is the least, it's practical, it's easy to look up, but it assumes that kids in an age range are very similar kinetically, and they're not. So if you only have age-based, that's one way to go. If you have something other than age-based, it's good to use that. So if you've got weight-based dosing, that's better. If you're in an area where it's not known, you can always look at 2. Look at age-based recommendations, look at weight-based designations. The problem we're getting into is that kids are fatter and heavier, and so the weight-based dosing can get into trouble because with obesity, kids can actually have very large dosing recommendations based on those weight-based. So just a reminder, the adult dose is considered max. We don't exceed the adult dose for an obese or overweight kid. Let's see, body weight. So if you look down at body weight, and we're going to use that a lot today. It'll be milligrams per kilo per dose, milligrams per kilo per day. And then you have to divide it up depending on how often in the day you're going to give it. And usually then it's more divided into groups that are much more kinetically similar. So here you see neonates, infants, children, adolescents. Usually that's the designation. So So on that weight-based, next page, it is the most common and probably the most used. It's still fairly easy to use, easy to access. Disadvantages I've talked about. Body surface area, you won't see that as often. You'll see it in where there are drugs that are much more complicated or more toxic, like chemotherapy is based on body surface area. And you won't see it with you won't see it with every drug, whereas with most of them you're going to see weight-based at this point. Disadvantage is the calculations are much more difficult. You've got to have accurate weights, and that goes for the weight-based as well as the body surface area, and you've got to have your height as well. Under disadvantages, still not a well-studied approach. Doesn't account for all the differences between kids and adults in terms of kinetics. So those are the three areas: age, weight, and body surface area. Conversion of adult to pediatric doses, so you'll hit some drugs where there isn't a recommendation. So things to look there are what's been published, people that do a lot. My colleagues over at OU that were in pediatrics, they were writing papers all the time because their group and the physician groups that they were in, they were always looking at what worked and what didn't work. So pediatrics tends to publish a lot of limited case series or cases of what went well, what didn't go well. So there's a lot of pediatric literature with regards to dosing. So if you get into those areas, that's the place to go. If you are in a large group, either a hospital or like Kaiser or a large conglomeration of physicians and practitioners, you're going to have pharmacists that will specialize just in pediatrics. And within pediatrics, you will have pharmacists that will specialize just in neonates, preemies. Make friends with them. Make friends with your pharmacists who are more geared or practice a lot in the pediatric area. They will help you here in terms of when you get into an area where you're not sure how to dose. Any questions there? Comments? Should be a refresher. A couple of things. Kids are not little adults. They're very different, especially kinetically, especially how they handle drugs. And neonates are not small children or small babies. They have their own unique set of problems because of how developed their liver or their gut and their kidneys are, or in their lungs. Remember, it's a diverse population, so kind of think about these terms. We introduced them very early on. So you have preterm neonates. They have a term. That term is based on their weeks gestation when they were born. Neonates are that first 28 days. Infants are 28 days to a year or 12 months. Children are 1 to 12, and adolescents are 13 to 17. Some, like asthma, will shift the 12-year-olds into the adolescent or an adult group. So that kind of varies depending on the data. Kinetics, let me go back and just remind you, very different kinetics in kids. Infants have the most rapid growth in liver maturity over that year. Okay? Kidneys develop or still have a ways to go in terms of their metabolic clearance, but they do it at a fairly consistent speed, and they're a little bit earlier than liver. So absorption can be different depending on how mature the gut is. The liver, that first year is really important, and for some drugs, the rate of metabolism gets really fast up until about 12, and then they assume a more adult appearance. So kids kinetically will change from neonate or from preemie if they're born premature to infants to children to adults. Some drugs, it really makes a difference, others not so much. The other things, we talked about this, but just to kind of a reminder about smell and taste. So sweet, we're born with it. Probably goes to our survival. We survive on carbs. The taste of bitter or sour or salty develops at 2. When Cameron hit 2, he could not get enough of lemons. I swear, I'd cut him up and he'd just suck them. It's like, but I don't know what that meant, but that correlated a lot to that when that developed. Texture and temperature perceptions by about a couple of years of age. And then smell doesn't mature until about 5 or 7. So those are going to affect how children deal with the taste of medications. You want to add anything? I'm just going through review, but you're welcome to chime in there.
I might have a pearl for you, Dr.
Oh.
Latasha. Did you know there's a handheld thing you can bounce?
There he is, yes. Yes. I can only seem to handle what, because I lose my handout often.
Oh, okay.
I'll lay it down and talk to him and then I forget. But thank you. Anything you want to comment?
No.
To this point?
This is all good information.
Okay, let's see. Oh, that's a little bit premature. Okay, we're on the middle of page 3. So, unlike adults, children often, what you want them to have and how you want them to have it is not commercially available. So that often has to be extemporaneously compounded. There are pharmacies that specialize in compounding. After we've had some major mistakes in compounding, especially on the East Coast, there's more and more regulations. So most pharmacies won't do a lot of compounding because it takes a lot of time. It's expensive. Insurance does not pay for it. And there's more and more regulations on it. So there are pharmacies that just do compounding. And usually they're pretty good at it if they specialize in it. And they'll be really good at it with children. So what they have to do is, they usually belong to associations that have over time developed recipes for drugs. A lot of that will be based on what's in the literature, like solubility, like how do you know how soluble it is in a vehicle? How long do you know it will last? How long is it good for? So there's a lot of data out there, and usually those pharmacists specialize in that, or they will have pharmacists associated with them that will do that research. So there goes a lot into if you want to have something compounded for a patient. I would also say keep them in mind if you get into a situation where you're having difficulty getting a drug into the body. And this goes for adults as well. They're really good. They can tell you what can be put in a suppository, what can be put down a JPEG, what can go down other routes. They're really good at that. So keep that in mind as well. What can go on the skin, how you can get a drug into the body. They are the best at it in terms of pharmacists overall. If you're in the hospital diluting IV products, this is commonly, this is not uncommon, but a pharmacist also would be able to tell you, can you dilute something down? Often we don't do it because they put preservatives in things that go into adults that children can't do. So again, talk to your hospital pharmacist. They're experts at what you can do or how you can formulate something for a very small child. Let's see. Liquids, familiarity with the concentration of liquid products. As we go through, we're going to do this today. You're going to want to choose the least amount of liquid that you have to give to a child because most of the time they don't taste good and it's foreign, and so you'll get a lot of resistance. So we always want to go for the least amount. So we're going to look at what's the most concentrated that will get us the amount that we can use probably to the best of a parent's ability and a child's ability to take down. Assure that calculations for a dose are based on the correct concentration. So you'll see this as we go through. You'll have very dilute when you're dealing with a really small child and you are having to do a very small dose, then you want it as dilute as possible. And you'll see that like when we get to ibuprofen, but as the kids get older, then you're dealing with these big volumes and they don't want to drink it down. Kids, it takes till about the age of 6 or so for a kid to be able to take a tablet. Then you have to kind of teach people, how do you swallow something that you're not going to chew and you want it to just go down. Some kids develop later in that, some a little bit earlier. So you're at that point, you may be dealing with fairly large liquid amounts that you're having to prescribe, and you'll see that today as we go through. Work with someone who will check your work, always, especially when you start getting out. Don't be offended when people want to check your work. Or if somebody calls you and said, I can't make this calculation work. Always thank them because they have saved your butt, but more importantly, they have saved the patient. Okay? So I'm never offended if someone checks my work. I often will hand it off, and especially if it doesn't come out like I expected it to, then I'll have somebody check it. That's why it's good to start to have in mind, what's an adult dose? What's a dose is too big, because then when you do your calculations, if you're off by a factor of 10, you'll catch it. Or you'll go, oh man, this isn't right. You'll give it to somebody. When I was a resident, I had to work in the county pharmacy in Bexar County in San Antonio. And often my assignment was to the high-morale TPNs. We would make 100 or more TPNs a day, probably even more than that. We might have had 100 patients, so we might have made 200 or 300 a day. So we had 3 sets of check. The tech did her calculations, and we had a chief tech who did that, and then I checked it. So we had 3 checks in a row. Never be offended. Always ask people because it's patient safety. Let's see. Dosing recommendations for obese children we've talked about, not exceeding the maximum dose at the adult. Okay, other concerns, when you get into IM and IV for kids, you have to look at volume. So in IM, the amount you want to give may be too big for a muscle size or just from a comfort size. The other with IVs is you have to worry about how much fluid it's going to take for you to deliver that. Because kids are not going to be able to use as much or have the capacity for a huge amounts of volume. So those are kind of things to keep in mind. Oral administration, what is one of my axioms? Never change a dosage form unless you know it can be changed. That's where a pharmacist would come in. You go, I've got this problem, I need to do this, what can I do? Never tell a person to change a dosage form unless you know that doesn't change the essence of the drug. Liquids, errors in measurement, very common. One thing is I was going through these calculations for today, and I was thinking about the adults that I took care of. I can tell you that a lot of adults in Oklahoma cannot do math. So I would say, I'd like to hear from you what you did here, is that I would always make sure my parents could calculate a dose. Or I would tell them, here's the dose you need to give them of Tylenol or ibuprofen. 40% of the people in this state are stage 1 or stage 2 illiterate, so their reading level is low. Their ability to do math is very low.
I can't even tell you how many times I wrote out 5 cc's equals 1 teaspoon, and then I would do 2.5 cc's equals a half a teaspoon. Okay, so let's get in the middle there. 1.25 cc's equals a quarter teaspoon, and 3.75 cc's equals 3/4 of a teaspoon. And I would make that little chart on a Post-it note and tell them to go home and tape it up inside their cupboard door with their medicines. Also, you were talking earlier about the compounding pharmacies. The ones that I use most frequently in all my years have been Lassiter Drug, which is over near
they're excellent.
Middale. Oh, that guy is so nice.
They're the best in this city.
He really is. And then Chris Express Drug compounds. They're on the new one on the south side. It's a family-run pharmacy down on the south side, and they do quite a good job compounding for my pediatricians I work with on the south side.
Okay.
Also, when you get to teaching a child how to swallow pills, I know Tricia Irons touched on this briefly the other day, but we actually in our office kept Tic Tacs, and M&Ms, and we would start with a Tic Tac, and it's a mind game. If they can swallow their pizza on Friday night, they can swallow that pill, you know, it's just a mind game. But the one thing you don't wanna do is put a kid in a situation with their dad sitting across the kitchen table from them saying, you go and swallow that pill, because that's not gonna end well, it's gonna make memories that will last until they're in their mid-50s. Seriously. So, but seriously, you do the Tic Tac, and then a regular M&M, and then a peanut M&M, and once they've got a peanut M&M swallowed, they can swallow anything.
I can swallow metformin. I would look for things that are repetitive, and then I make handouts. So like for doing those dosing, I would make picture, things that I could circle. I would always make sure they get an oral syringe. That is your best measuring. Yes.
Every office I've worked at, I've had them order in the 1cc, you can order from any of your medical suppliers, just syringes without needles. The 1cc is it's considered a diabetic syringe, but that's perfect for your infants on ranitidine. So you do 0.7 ml or something like that. And I would have them order in a 5cc and then a 10cc. All without syringes, and have those ready to hand out. And I would take a Sharpie too, and I would often mark on there all the way around the kid's dose.
I often did that with adults where I was really unsure, or if I didn't think they saw well, I would always mark it with something, and I'd put tape over it. Because on some of those syringes, over time, the barrel markings will wash off, or they'll just rub them off. So those are really important. Making sure they have accurate measuring. Some of you are not writing this down. I'm telling you, that's one of the most important things, is making sure they have something that measures well. We kept in our clinic what do they call those? It makes a second copy, but you don't have to worry about the...
Dr. Johnson does the same thing.
I just kept it, we made them up, and I wrote everything out. And I also, if I was going to tell them to get something over the counter, I wrote it and I said, take it to your pharmacist, show them this, and they will help you find the right thing. So you gotta have something that you can write down, and then I could keep it in the chart, or I could scan it into the EMR that this is what I gave the patient. Okay. But for those things that are repetitive, make something that then you can give them, but make sure they can read it. So I always handed it to them, say, can you read my writing? And that was the easy way to get around, and then I'd have them read it back to me. To get around and if they told me they forgot their glasses or stuff, then I started to remember. I started to know they couldn't read it. And then we rehearsed it. Let's see. So here's your picture. There's that oral syringe. If you've forgotten, it looks just like a syringe. You can also get those little adapters for bottles that will help him draw them out more easily. Don't use teaspoonfuls. Don't use the spoons out of your silverware, because they're not standardized, and so they'll overdose or they will underdose a patient. Don't use the measuring spoons. Droppers depend on how well they're calibrated and what they look at. And then the dosing cups, remember we talked about this before, you get a meniscus, so you get the whatever we call it, the static energy on I can't even talk today, up on the sides of the cup, so they're going to look at that lowest point. Okay. Now, it depends on how they look. If they look here, if they look there, if they look down. So that's why people don't like that to use it as much, especially when you get the low doses measuring out for very small children. They're not very accurate. Remember we talked about tricks to make the medicine go down? So Flavor RX is out there. Pharmacists, you can ask them. They will usually, for a small amount, add to it. Our pharmacy asks, especially when we get into medicines that I guess they frequently modify, they will tell us. You can also use, of course, we talked about the chocolate chasers before and after to coat the tongue. They make these different med cups in medicine bottles for infants that you can use. You had experience with those?
Yeah, I'm not a big fan of those, just because if the kid doesn't drink it all, you don't really know what they got.
That's true.
You know, so I kind of always discouraged those and just went for if they're small enough to want to suck, they'll suck right out of that oral syringe. You know?
Yes.
Yeah, so, but the chocolate chaser, that's my fave.
Yeah.
Absolutely. Something about the chocolate syrup just cuts that bitter. And plus, just randomly, when the kid's not even taking medicine, give them a squirt of chocolate syrup, what the heck? Seriously. Teach them not everything yucky comes out of those things, right? I use the cups, I would recommend for the cups, because sometimes the 10 cc syringes don't fit down in the bottle to draw it up. So I would tell the parents, take the cup, pour out what you think is the dose in the cup, and then suck it up into your syringe.
Oh, yeah, that's a good
And
idea.
excess
Yeah,
chemicals.
the barrels are too big for the,
The barrel's too big for the spouted bottle, the neck.
I didn't put this in the handout, just a reminder, the number one cause of trouble of pediatric dosing errors is a just miscalculation in weight. Really important. Accurate weight, the conversion, if you're having to do, almost all of your dosing recommendations are gonna come in kilograms, and you're gonna weigh them in pounds. So today every kid we get is gonna be in pounds, and you're gonna convert them. Converting a daily dose into a divided dose. Or some of them will give you the dose and you have to then convert it into how many times a day. That's not a very common one, but it's paying attention to that interval in the recommendation. Conversion, the dose from milligrams to mils, or confusing them. On the top of page 5, these are some of the dosing medication references. The one at the top, the Pediatric Neonatal and Dosing Handbook, that is the best. It's very good. They update it on a regular basis. So if you had to have one, that was one I would recommend. Neofax is considered the gold standard for preemies. Pediatric injectable drug, if you are in a hospital, your pharmacist will have these. And we'll consult them. That's probably the handbook of choice among pharmacists in hospitals. The Red Book is the American Academy of Pediatrics. It's for its antibiotics, so you'll see a lot of recommendations. Even in what we do today is going to be based on the American Academy of Pediatrics. Very good group to be familiar with. Dosing recommendations, they will vary between references, because they'll look at different data. That's what's kind of aggravating or worrisome about PEDS is just depending on what your reference is, what you're comfortable with, and when there is more variation than you're comfortable with, always go to references. On the prescription, these are the important things on a prescription. Always include their weight. So when you do these prescriptions for this next set, put the weight on. The more things that you can put on the prescription that then a pharmacist can check, the better off you are. So if you put the dose in milligrams per kilo per day, gives them another check. Putting down, and some of you already do this, putting down the milligrams, if you are going to dose a liquid, is put the milligrams and you're putting in mils in parentheses or vice versa. So you'll see it with ranitidine. It's 15 milligrams per mil. So if you're going to have 30 milligrams, you put 30 milligrams in parentheses 2 mils, or 2 mils in parentheses 30 milligrams. So pharmacists can always cross-check. Select a dose that the parent or caregiver can measure easily. So we're not going to use tenths of doses. unless you're dealing with really, really young kids. We're going to round things up, but we're always going to make sure we're in the dosing range when we do that. We're going to round weights as well, and we'll do that today. So usually most of these drugs are going to have a range. So as long as you're in that range, then you're good. Use leading zeros. Do not use trailing zeros. Okay? So that leading zero will draw the eye to that decimal point, but a trailing zero, maybe instead of 5, you see 50. Okay? Remember that? Avoid abbreviations. Some of you love your abbreviations. Do not use them unless they are standard. Okay? Wherever you work in a region, people will have little things they develop over time. Don't use those. At least start out doing it the right way. Because, you know, in physics, everything moves to a lower order. It's entropy, the law of entropy. Everything moves from high energy to low energy. It's the same thing. I told you about when I moved to Texas, I let my driver's license lapse, and I had to go take a driver's license test when I got to Texas. Well, I failed it because I was so, you know, he said you cut every corner, you roll through the stop sign, everybody gets sloppy over time with stuff as you get comfortable, okay? So do everything right at the beginning. And your preceptors are going, oh, I tell you that in school, but you don't have to do that. Do it right until you figure out where the shortcuts are, maybe not the latitude, the give in the right is. All right. Okay, we're going to come back and we're going to go through the different topics. So why don't we take a break here and then we'll